Hello, I'm Patrick Daly and I'm one of the team at the Rural Doctors Association of Australia. Each year, RDAA and the Australian College of Rural and Remote Medicine offer excellence awards that recognise some outstanding rural generalist doctors and some inspiring future doctors as well. I've been lucky enough to spend time chatting with 4 of our awards recipients for this podcast series. Today's podcast features Dr. Diana Cross, the recipient of the ACRRM-RDAA Peter Graham Cohuna Award for 2021. Diana has been a rural GP and GP Obstetrician at Mt Gambier in South Australia for more than 37 years and received this year's award for her dedication in providing exemplary care to her community. Diana credits her colleagues at Hawkins Clinic in Mt Gambier and the community itself for enabling her to have such a fulfilling career in rural medicine. Before I begin talking with Diana, I'd like to acknowledge the traditional owners of the land we meet on across Australia as we listen to this podcast. I'd also like to pay my respects to elders past, present and emerging, and welcome any Aboriginal and Torres Strait Islander listeners who may be joining us. Thanks very much for joining us, Diana, and congratulations on receiving the ACRRM-RDAA Peter Graham Cohuna Award for 2021. What was your reaction when you were told the news?
I was very surprised and very humbled because I feel like I haven't done anything extraordinary except have a wonderful career in the country with people who've put up with me and supported me and made it as rewarding as it has been.
So I understand you didn't grow up in a rural area. In fact, you were raised in Adelaide. Tell me a little bit about your childhood there.
Well, Adelaide in the 60s was a bit rural still, but my parents were new expat POMs, and Adelaide at that time was full of POMs, and as newbies they quickly joined in with the others, and particularly in the medical fraternity, of which there was quite a number of similar. And it was amazing because they were united, and we went and had afternoon tea or tennis parties or nights with the range of specialists. There was no just a GP type thing. We were with dermatologists, orthopaedic surgeons, obstetricians. They knew each other, they related together and supported each other. So it was a bit of a time capsule in Adelaide's life, particularly in the medical sphere anyway.
So your father was a GP and your mother was a midwife? That's
right, yes. If you look at Call a Midwife, that was their experience. When a friend of theirs suggested perhaps going to Australia, they thought about it and came out.
But despite your father being a GP, I understand medicine wasn't your first choice as a career path.
Yes, I think I, as a child, had some notions that I'd be in the medical field, but I hadn't had exposure to many other careers apart from those things, and I knew that our life at home was dominated by the 2 black phones, one which was a private one and one which was the practice one. But we'd learnt to adjust to that, and in those days you didn't have mobile phones, so if you went out, you were out. No one could call you. So I think I enjoyed school. I had the benefit of a good education, and I wanted really to do something in the health field, but I simply didn't think I was good enough to do medicine. I hated physics and chemistry and maths. I was a biology girl all through. And so I was thinking about speech pathology. It was a new course at Sturt, and I had a cleft palate. So I was kind of interested a bit in that. or nursing, obviously from my mother's background. But it was really just because they encouraged me that I actually applied for medicine, just to honour them. But I didn't expect to get in. That was the way I was approaching it. So it was a surprise to me when I got in, but I wouldn't get in on the current criteria, I'm sure. Fortunately, the Flinders Uni course was starting. There was 2 years in by this point, and they, provided you got above a certain entrance score, you could get in with any subjects. So I was fortunate to get in on the basis of English, biology, geography, music, and ancient history. So biology was my love. I loved it. It gave me a head start on all the physics chem heads who were in that first year.
Yes.
And a quarter of the course was elective at Flinders. So in that first year, those of us like myself were directed to do biophysics, biochem. I just learnt it by rote. I didn't understand it and just scraped in, and then past that and on we go.
So then what got you interested in rural medicine as a career path?
I think there were several factors in that. Certainly the practice that my father had was a broad practice that included obstetrics. The obstetrics was in the form of a roster, a month each of the GP obstetricians in the Brighton Glenelg area took on a month's rota to cover the Kate Cox home, which was for unmarried mothers. I think the other thing was there was such a thing as electives in that part of medical course, and I had done one of my 6 weeks electives. I elected to come down to Mt Gambier Hospital and do obstetrics. So I basically sat in with both of the specialist obstetricians in town at that time, very eminent doctors, and also sat in on their clinics and that kind of thing. So I'd been to Mt Gambier. I knew the setup of the clinics. I'd also seen the hospital, and I loved the place. The staff were welcoming, all of that. I know that's really effective for those who come to the country still.
So you began working as a GP and GP obstetrician in Mt Gambier in 1984. Has obstetrics been the main love of your career, or have you found significant interest in your general practice work as well?
I've always loved the patients, and I think that's been my first love, and what I could do for them. I also just loved the general practice work, the variety of it, and the good thing in the setup we had was that you developed your own sort of cohort of patients who you got to know over time, and you got to know their family, and then you were involved in their births, and it was a whole family experience. That was a great joy of the way things were set up then.
So how has the style and scope of medical practice changed in Mt Gambier over your time there?
It's probably only changed a lot in the last 10 years, I would say, and that's gone along with changes in Medicare, changes in how our practices run and so on. We've been a private practice all along, and I was one of a partnership, and we decided how we ran our practice, and we decided that we would not be a bulk billing practice. That meant that we did charge a fee, but that also meant we could spend more time with patients. And that was appreciated by them, and we liked that too. And that was sustainable while there was no other bulk billing practice in town. The other clinic, because there were two main clinics, the other clinic also had the same kind of approach, and that philosophy suited me because I like taking time in my patients. I think that reflects my needing to just settle and be able to be present and listening to them, as that's my style. And the women that I mostly have had in my practice, I don't think I would have survived in a bulk billing practice because I can't seem to get the quick in, quick out, just a sore toe. That's the only thing you talk about.
And in fact, those who nominated you for this award highlighted your commitment to your patients and really taking the time to understand their concerns and also the factors contributing to their illnesses or conditions. I'm interested to know what level of importance you place on this in determining the causes of disease or illness and subsequent treatment options in terms of family history, personal circumstances, and other factors that might be overlooked or not given much credence in a shorter consult.
Sure. It's a richness of understanding of the patient that you bring to the consult. I had been there a couple of years when I approached one of the other partners in the practice to ask something about a patient. And he said to me, "Oh, yes, that's so-and-so's child. Oh, yes, the grandmother's got such and such." And yeah, and he just knew the family tree. He knew them. It wasn't a head knowledge. And I was just impressed deep inside that here was someone who knew and loved this family, had that level of knowledge, had that level of concern and connection. And if anything, that in a way sums up what I felt country general practice was about. And, we were involved at their births. We were involved then with those babies becoming children. It was a wrapped up all in one thing. And you got the level of respect because they knew you as well and they trusted you. It is very interesting, even although that has broken down somewhat with families moving in and out, but someone waltzes into your chair and says, "I don't know if you remember 28 years ago, there was a lady who had a baby that birthed rapidly at home and then went to hospital, and the midwife found there was a second one on board." And I said, "Yes, I do," because I felt so embarrassed that with scans as they were then, that we'd missed the second one. And she says, "Well, that's me." And I said,
Right.
"Hi."
Wow.
Those kind of things that are just sort of special to me, in the sense of she'd come back because they have an inherited trust of you that's passed on from their parents who hold you with love and respect. And that's an honour and it's a trust and it's something that I value because of the relationships and the that knowledge that builds up.
How important is it as a GP to really listen to patients in the consult, to take that time to listen?
For me, it's very valuable, and I know it's probably a female approach, and I know I see a lot of females. Somewhere early in my career, I saw an advert for some drug, and it was a picture of a male doctor in a white coat standing at the door, giving a handshake to his patient, and it said something like, "This is good practice." And it really struck me that wasn't me. I don't stand at a white coat. I don't stand at the door doing handshakes. And it was like, okay, this legitimizes my female practice where sometimes we give a hug. We sit down and we talk, and I'm not saying men don't do this, please get me straight on that, but just for me, I find that if I sit down and talk with them, I need to connect and listen to them. So I cannot type on the computer. I jot with my right hand on a piece of paper, but I can't type and not have eye contact and feel them. That's me. That's how I relate to people, and I need to connect, and that takes time. So I've had a different practice, and I recognise it, but for me, that's what's made it valuable, and I'm hearing that that's what's valuable to my patients.
Have there been times when really taking the time to listen has come up with revelations in consults that you weren't expecting?
Certainly. And it's also, and some of those revelations, not just them to me, but me clicking with where they're at. For instance, a patient the other day who I know well and has had quite a problem with anxiety, but it was on a day when I really needed to catch up, but down she sat, and this was the day when she was just revealing that last little piece of information that helped me understand her. And I just couldn't miss the moment. I couldn't miss it, to sort of then feedback how that was actually underlying her blood pressure that she was coming to me about, because I didn't think she'd made the connection there. But because I had the background trust, because she'd given me that chink of information, I then could actually make that linkage, and she could hear me and take it in. You know, those are very precious moments. They don't happen very often, but I think it's important that, you know, we are able to be the people who make that connection. If we're rushing in and out doing blood pressure all the time, we sometimes don't get that.
Is it sometimes that there's too much of a scientific approach to medicine and general practice, when sometimes the human interactions make for the really important moments?
I agree. I think there is. We have to hold our patient in one hand and the science in the other, and know that the science has usually been, you know, a randomised trial that has excluded individuals and with their comorbidities and their underlying issues. And we do have to try and marry the two and bring the relevant things from their history to bear on those randomised things, and vice versa. You can bring out your guidelines, even say for the heart risks, but that doesn't, the scales don't include the genetics. The scales don't include the psychiatry aspects of them. It's got to be a blend, and that's where I think is the art of general practice.
How much more has psychology become a factor in general practice consultations, say, over the past decade for you?
It's a huge part. I mean, it always has been, but it's become more so because of the stresses and strains of modern life. I think I was able to get a handle on this because early on I got seconded in to fill in for another GP who was co-running a course called Mind Over Mood at the hospital, which was basically using cognitive behaviour therapy and those kind of things, and teaching it and taking patients through in a group. And as is often the way, your best insights come at the most embarrassing moments. But as I was teaching about the symptoms and signs of anxiety, I suddenly realised that I had the condition myself.
Right.
But I'd always talked to it as shyness. I now had a handle on it. These are things I could do. These are things I could treat. So I then saw a whole new world for me as far as what I could do. It also led me to clinical hypnosis, and amongst, past the whole showtime sort of hypnosis, the clinical side was fascinating because I realised it was all about the power of language and learning a new language, a childish language or a language of stories and pictures. And I just went straight into that as if I was a natural. And whilst I don't do clinical hypnosis in my clinic, I use that knowledge in how I word what I'm talking to patients about. So on this particular day, I mentioned about this patient who came in with that last little clue. I was just able to straightway move into what language I knew I could use in that situation that would just open it up for her. And it was a very powerful moment. That sort of medicine is what you do all the 97% of your medicine for, is those moments that actually change things more powerfully than a pill.
You undertook a 2-month locum placement at Nooka in Arnhem Land about 8 years ago. What drove you to do that placement, and what did you take away from your experience there?
Yeah, it was done in part of my long service leave. That's another privilege, that as a clinic and partners that we accrued long service leave, and I wanted to get an insight from the Indigenous side of things, of what healthcare was about. I must say my time there came hot on the heels of a 2-week bushwalk. So that's my non-medical love, is going with groups and walking right out in the bush off track for a week or two. And I had done a 2-week walk in Kakadu right off track. And in interacting with the landscape, with the Indigenous paintings, being very respectful of the places where it was off limits to us, that sort of thing, I really could get, I thought, some of what they have in their relationship with the land. And so it changed my thinking, it changed my talk from being, you go to the country, to you go to country. Country is a person. Country is reflecting your past and present and future elders. All of that, I suddenly sort of got that. And in that sort of mood, I went into Nooka, and I could see how we had still got a very different perspective of healthcare. In Nooka, it was different than elsewhere because the elders were educated from the mission that had been there previously, and they had been able to get a level of autonomy because of that education to at least have some level of input and influence. So they ran a service each night where, as women were the main power force, the women ran a bus that would go out to any particular dispute in a family. They would sort it out and deal with it. They'd build a men's shed, they'd build a women's shelter separate. and they would sort things out, and only then, if need be, would police be involved, and very rarely were they. I also saw the benefit that they were far enough away from most of the wet that alcohol could be kept out of community. But when it wasn't, what that did, I saw the benefit of those things, but I also could see they were very much in the dependent thing, that we had a driver who went round and got them. There wasn't any sense of how we wanted them to interact with an appointment system. That wasn't going to happen. I also saw a young guy of 20 who was really caught between systems of respecting his elders and what they wanted, but also being caught up in a police system, how to respect that, but go against what his elders wanted. It really gave me a lot of insights and a huge respect for the difficulties they have in interacting with any healthcare system. Even though they'd got some good aspects of that, there was so much that still seemed very difficult.
So what lessons did you take away from that placement in terms of what needs to happen with health policy to affect change in Indigenous healthcare?
I think first and foremost, we go to listen. We go to listen, to hear their hurts, to hear their knowledge of how it works for them and how it could work better for them. And we try to work with them, not get them to work with us. And in respecting the hurts and difficulties of the past, I think that's also very important with this whole COVID vaccination issue, where there's a reluctance because of what's been forced on them in the past. And I don't think that sort of coercion works well in that setting at all, let alone any setting.
What have been some of the most challenging times of your career in medicine?
Yes, the most challenging times have been adverse outcomes or disagreements with colleagues. The patient who suicides despite you doing what you could, the babies who have a less than desirable outcome despite you doing what you could. I think that's universal in medicine, where you care about people. And I think that certainly comes home when you're involved in a legal situation, which I have been for the last 5 years. But if anything, it brings out the colleagues' support in the midst of those things. So I see it as essential that you have colleagues, and I don't know how people do it if they're doing it solo. In Mt Gambier, we've had that, and as a partnership where we really work together, while we weren't in each other's pockets as friends or anything else, but that support, even just in the background. Of course, we had different interests and different inside and outside of medicine, but there was always, as a junior anyway, the backup of his senior colleagues who were more than willing to help and more than willing to give backup in many ways when you ask for it.
You're a proponent of alternative forms of medical treatment like frequency-specific microcurrent or FSM for pain management, and also nutritional management of chronic conditions. Tell me a little bit about this, and do you think all GPs should be prepared to think outside the box in healing a range of conditions?
Sure. I wouldn't say they're alternative. I think from my point of view, they're essential, but they're the bits of medicine that medicine has decided to to leave out. So, of course, there's a vacuum. So, I mean, my interest initially was in nutrition. Let's say I had anorexia nervosa as a adolescent, so food was very much in my interest. But probably after about 5 years in practice, I had glandular fever and got chronic fatigue. And for 12 months after, I needed to sleep at least 12 or 14 hours a night to survive. And I realised some of the shortfalls of medicine in that respect. And so had to look a little bit more, not only at sleep and nutrition and balancing things. So I took away a lot of things from that, as well as the importance of the gut and those sorts of things. And I became involved in the Australian College of Nutritional Environmental Medicine, ACRRM, which was also pioneering that side of things at that time. I also was interested in pain management and musculoskeletal medicine, particularly the bits that we didn't get taught. I don't know about you, but I was taught about these things from orthopedic surgeons, and that left out a large part of the soft tissue work that's part of general practice. I mean, the only thing they could recommend was go see a physio, which is great. But in terms of general practice life, that wasn't always, people came to you for advice, and you needed a way of managing those things. So I'd already got that sort of in the background. I went along to a pain session that was organised by a GP who'd done acupuncture over in New South Wales. And at that visit and at that conference, they had people who did clinical hypnosis, nutrition, and so on. And I sort of saw the connections between all those things, that you couldn't just treat the medical side on its own. And that piqued my interest. I went off and did a course run by, again, a GP who did nutritional medicine, and really sort of enjoyed that and started to put it into practice with my own patients. I then moved along from there and went also to a conference about that included a speaker who, Dr. Carolyn McMakin, who suddenly started talking about microcurrent therapy. As is common, I had a bias at that point against chiropractors, and she was an American chiropractor. But as she was lecturing, I heard her talk about pain in a way that I didn't know, and a therapy I didn't know, and which dealt with trigger points and soft tissues that nothing else could seem to do. My skepticism, I went and talked to her and found her to be highly knowledgeable, highly intelligent, very scientific based, and wanting to get to the bottom of why this magic worked. So I then took up that and used it in my practice. I found that it worked for things that nothing else did. I found that you needed to look at nutrition as well if you were going to get a body well. So gradually I sort of integrated some of those things, and then took over a support group for all of those who were using therapy in Australia. And 3/4 of those were people who were not doctors, but alternative therapists. And that gave me huge respect for where they came from. And also an insight into how we might need to support them with a knowledge base that would make them safer. So I guess that's where I've come from.
Do you think there's growing acceptance or a growing willingness to look at these sorts of therapies from mainstream general practitioners, or is there a way to go yet?
I think there's still a ways to go. I still feel there's an attitude that alternative therapists are all wacky. I still think there's an attitude that they're on pseudoscience. The problem is that our medical journals and sort of literature we look at don't even touch base with the huge evidence base that there is for some of these other issues. And I think it's rather naughty of us not to recognise that our own evidence base for much of what we do, apart from diabetes and heart things, is pretty limited. So I'm sort of middle of the road in there. By learning more about alternative medicine through sources that are scientifically based, I feel there's a middle way. If nothing else, we shouldn't just be critical of these therapists, because I find in them a heart to help patients, which is sometimes has shown us up as GPs. I know you need the heart plus the head, and I get that. But most of the time, we haven't taken the time to even know or discover what these people have learned and how much we could actually cross-fertilise our own thinking.
Do you think there needs to be more emphasis on teaching alternative approaches to medicine at medical school?
I do, but in the shorter and shorter courses, you're lucky to get it all in. The good thing is that students these days have come from a broader background. They're not starting off just age 17 with no experience of life like I was, but they've come with a broader background first of all. And I think it behoves us to realise these influences on patients. I have patients who come because I talk to and understand these other therapists, and they are open with me. When you give permission to people to tell you, they will tell you that they go to a chiropractor, or they will tell you that they go to a naturopath. And I listen. I don't chastise. I'm interested to hear what they have been doing. I then support the things that have got a research base out there. I then indicate where maybe something might not be really so good. And that way I feel I can work best with my patients rather than have an attitude of just dismissing the alternative therapists and in fact telling my patients to shut up because I don't believe what they're doing is right. I am not saying that I endorse all things that happen by any means, but I'm respecting the patient's choice and then informing them so that then that choice may be better in the future. I think that gives me at least their ear to talk with, rather than just saying that's all rubbish and you're stupid for going there. How can you communicate with people on that basis?
I understand you're driving some clinical research into FSM. Tell me a little bit about that.
The developer, Dr. Carolyn Macon, had a theory that she put out there initially, and it didn't make scientific sense to me, but it was just an effort to try and explain what we saw, this the significant reduction in pain over 90 minutes of using just one frequency pair of people who've been in 8 out of 10 pain for over 10 years. How could this be? It was validated through measuring cytokines in fingertips and seeing them go back into the normal range, whether they were raised and went down into their normal range, or they were low and went up into their normal range. This to me had to have an explanation. And so I love reading, I love understanding the body. I just delved into the literature, any literature, to sort of start to understand how does the electrical side of things work in our bodies. And through that, over the years, I've now sort of gradually inched closer to a theory involving microRNA. When I first started this, microRNA were hardly existing in the scientific world. So it's been a fascinating journey and kept me alert to where things are at scientifically wise, and getting me to a point where I want to write a paper so it can generate a study. But it's been fascinating to sort of understand a bit broader than just general practice and some of the science behind what's happening.
You have a swathe of interests outside medicine, including, as you mentioned earlier, bushwalking. Tell me a little bit about these and why they are important in helping you with your work-life balance.
As anyone will know, when they get on the other end of a tennis court from me, there's probably a little bit of the aggro of the week coming out, but right. Hopefully I'm diverting it into a nice shot, not any other way. So I think physical things are a good thing to have, whether it's gardening or sport or running or something like that. And in the community, country communities are very much into sport, and it's a way to sort of meet and match people and get the head out of the medical world.
And you also write music, I understand.
Just dabble. Another sort of way of expressing. I mean, I had the benefit of learning to play the piano when I was young. My dad had learnt it when he was in his 20s, and as one of his things he wanted to do for his kids was to enable us to learn the piano when we were young. And I kind of went as far as I could tolerate learning the scales. And then as part of my involvement in a church setting, was often playing music there, not on organs, on pianos. My brother's the organist, he's brilliant. But that was some way in which I could express myself too. So at home, I just find sometimes these things happen.
You've mentioned that you find having quiet time at home not only an enjoyable but an important time for you in your week. What do quiet times mean to you?
I guess living alone, it is quiet, but I've someone who, particularly when you are spending time with patients through the day, you do need a way to unwind and to process things. I've been blessed by having a very close friend who's equally attuned to her heart and non-medical, so that's been really good. And early on, I learned the value of journaling. It's now become a sort of hippie way of doing things, to journal, but I found doing that in a sort of more worship context was also helpful, just in writing out whatever's there and then listening to some sort of wisdom and healing answers. I found that has been really crucial when things have been difficult. It's really been valuable for me in this last couple of years where I've been going through a very difficult legal scenario, and being able to walk to music and all those sorts of things have been very central in keeping me grounded.
Well, Diana, thank you very much. It's been fascinating talking with you today. I've really enjoyed it, and congratulations again on your award.
Thank you. I feel very privileged.
And that was Dr. Diana Cross, the recipient of the ACRRM-RDAA Peter Graham Cohuna Award for 2021. I hope you've enjoyed this podcast, and I look forward to having you tune in again. Until next time, happy days.